minutes, we will be having a quick question answer session. Whoever has got any question, please raise your hands and we can proceed.
So we expect questions from the audience. Okay. Don't try to save 10 minutes. It will be useful. Huh? Okay.
If we don't get questions, I think we will start asking them.
Asking you question.
So it is better you ask us first rather than we asking you.
Parthivan, sit. Let them front. Let them sit front. Yeah. Yeah. Questions from the audience.
Okay, we'll ask. Okay, we'll start from here. Yes, please. Okay, we'll start with name the rotator cuff muscles. Let us keep this session a little informal.
Yeah, little,
so I think it's better we use this idea to exchange.
Yeah, otherwise we can ask them what you understand from each speaker, at least something you can say. One person. From morning you are listening. Okay, what you understood. So at least 1 point, some take home message, something like that.
And welcome Aarti madam.
Welcome Aarti madam. Yeah. Otherwise we have to ask about Navin's smart integration technique. Huh? Yeah, just tell, at least share your list. We want you to speak, at least some 1 or 2%. Yeah, can you come just, anyone? There is nothing right, wrong.
Should have, it means either you morning, either, okay, what you want. You should ask questions, then only you will learn more.
Okay, I think no need to force so much. Huh? We'll just see our thing. Yeah, I'll start the question with Nandan. Okay. Yeah, Nandan is expert in treating most of the frozen shoulder cases and all. Okay. So, what my question to Nandan sir is, there are so many stages in frozen shoulder. Okay. The patient comes, you treat the duration or some other thing we can see for the transition of some painful stage to frozen stage or thawing stage. How we can say this thing? Or how you approach the treatment based on the patient presentation?
I will again go back to my talk which I told you about global restriction of range of motion. Yeah. So most of this frozen shoulder, when they come to us, they can come at any of the 3 stages, either at the freezing state, the frozen stage, or at the thawing phase. So you need to first classify which stage they belong in. So the most important thing I think is you take the history of the patient, and at the end of it, you should look at their total range of motion deficit. And then looking at the total range of motion deficit, if it is more than 70 degrees, the total range of motion deficit more than 70 degrees of active and passive range of motion, then I think we should look at it using all the possible techniques which were discussed in today's topic, including Navin's smart integration technique and APTER protocol, which was taught by Raj Kannan. And we have been using a modification of these techniques in our practice, isn't it? Yes or no? Yes. We use maybe, when we started with our undergraduate time, we started with doing AP glides, PA glides, superior inferior glides, and then afterwards re-education and PNF patterns, functional movement patterns. So I would categorize on where they come, which stage they are coming, and design my rehabilitation protocol accordingly. So to go further into whether this patient along with frozen shoulder has a rotator cuff pathology or any other form of shoulder related injuries like either a slap tear or an anterior labral tear, anything of that sort, we'll kind of categorize and then work on a rehabilitation plan for the patient. Exercise therapy and mobilization I think is very individualistic. The way I mobilize the patient to way Sumit mobilizes or Vinayak mobilizes or Dhananjay mobilizes will be different. But I think we are all trying to reach at a same goal for getting the maximum movement possible.
Parthivan, any inputs? You are sharing something to madam. You can share to us also.
Naveen has a question, I
Yeah.
think.
Doesn't mobilize. He mobilizes you to get better.
Thanks, Naveen, for bringing this. We don't allow others to watch how we mobilize. My expertise comes in mobilization only for the cyclist. I'll come back with Carvin to his
Yeah,
question. Thank you.
okay. So fine. So frozen shoulder, yeah, we have to see the stages. Don't do high-grade mobilization during the very painful thing. As the pain reduces, we can go based on the irritability. We can do. Yeah, that's fine. Thanks. Then, some cyclist comes with a shoulder pain. What is your assessment priority? Because see that what we are seeing the patient is different. On field, when they do cycling, they get some pain that is different. Okay, how you relieve the pain or what factors you consider because they want to go back and they have to finish the event. What is your important assessment and management in that aspect?
Thanks, Carvin, asking me the easy question. The cyclists can be of short distance riders or long distance riders. Generally, those who go for breves, like in one day they cover up 400 kilometers, 500 kilometers. Or there are riders who go for 1,000 kilometers in 1 week time. We go with them as a on-field physio support. End of the day, when they touch their above 70s or 100 kilometer, they land up with the upper thoracic common tightness and the pain which starts with. And as an orthopedic assessment, we do feel some tenderness and we think there's a tenderness towards the biceptal area because of the loading on the parallel bar, the bar which they sit and the handlebar do it. So we look at the muscle tightness and joint mobility, and then we analyze it whether it is to do with the thoracic tightness which is giving pressure towards the bicipital area, and we release towards intrascapular region. Mostly subscapular is the culprit, which David mentioned the similar way. So we work out on those muscles and the pain reduces on the bicipital region. So we look at it as a functional disturbance of the pain rather than targeting as an orthopedic based assessment. That's how we do it.
For pain, what is the common modalities or management you do?
Okay, modalities, we don't use any modality.
On field, yeah. When they are doing cycling, suddenly they got pain. You have to relieve the pain and then you have to put back. So what you can do?
The kinesio tape helps a lot in positioning the muscle structure. So we go with the kinesio taping on field. It can be a fascia technique most of the time. Sometimes we go with the ligament techniques. That helps a lot for the next day of riding to continue.
Okay. I think we move to the next person. One time is there, then we can. See, Uma, you practice lot of kinesio tape and rehab thing. Okay. Yes. Can you just share your inputs for maybe impingement or some shoulder pain condition where you use kinesio tape and how will you use that one?
Okay. Yeah, especially in those cases, painful shoulder, range of motion usually can be kind of restricted or it can be like full range of motion with the pain. So first of all, which we have to look for either the range of motion is restricted or the range of motion is full with the pain or not. So like in that way, of course, as Sir told, one common muscle like supraspinatus is one of other common thing which we usually notice. Along with that, upper trapezius tightness. So these are the two factors usually almost in 50 to 60% of the cases where the shoulder pain comes to us like kind of general shoulder pain when we just assess for like normal abduction, abduction. Of course, yes, this is the commonest thing which we usually say. The moment when we touch their upper trapezius, they usually winces with the pain a bit. So which is almost 50 to 60% common. So in that cases, of course, releasing the superficial muscle, the trapezius, upper trapezius will be much more better. And sometimes when you go for deeper palpation, underneath the upper trapezius is your supraspinatus, of course. So in that cases, yes, when you try to facilitate your supraspinatus muscle, that will give you a kind of a better, even though in a pain, at the same time in a range of motion, both concepts.
So any specific application of tape, any technique, what you follow in your clinic?
The commonest simple taping technique is like in supraspinatus, commonly when you just try to keep an arm flexion and a bit of horizontal adduction. So in that way, putting your anchor on your greater tuberosity of your shoulder, basically the humeral bone, and just applying a gentle stretch along the supraspinatus or the upper trapezius muscle. That will really, really makes a huge difference in the range of motion, especially in abduction. In such cases, sometimes along with that, we have to just look for even the middle fibers of your deltoid as well. So facilitating supraspinatus, we have to keep in mind one. Second one is like, of course, facilitating your middle fibers of your deltoid also plays a major role. When we do a taping, like kind of in Y-like structure, as we all know how to do a taping. So like in Y structure, when we do a deltoid taping, so that will make some more progress, I mean, in the range of motion. Like I usually check these two. So either in the first one, the patient usually say like 70%. The moment when I do a deltoid, like middle fiber of deltoid facilitation, they will tell 80 to 90% there almost a pain or the range of motion will be improved. So I always just check these two aspects. Yes.
Fine. Next we move on to Gautam. Gautam, you are dealing with more of the sports persons, I think. Suppose a cricketer, someone he comes with a fast bowler or something, he wants to increase speed from 120 to 130. What will be your thing? Because shoulder plays a very important role. Okay, in that aspect, because now we treat the patients as a sports physio. How will you go about it?
First and foremost, the assessment is very important. The fundamental assessment you need to take, that gives you a better picture of what you're going to treat. So assessment in terms of what we do is, so anatomical chains. So you have slings in your body, kinetic chains. So that is where we assess. So one example of anatomical chain is your shoulder is connected to your opposite glutes, right? If I'm treating a right shoulder, I'll assess up to the left glute, okay? So strengthening on the glute muscles sometimes gives a better power to the shoulder.
To the opposite
To the
shoulder.
opposite shoulder.
So glute you means medius maximus everything or especially maximus?
Maximus and medius.
Medius.
These
Any
are the two.
specific training other than the traditional protocol, what we do the same way strengthening, or is there any sport specific strengthening you follow?
Sport specific, there are a lot of exercises which is connected to your anatomical chains, what I was talking about. It's more of oblique kind of a training, rotational training. Okay? So if you take bowling in cricket, there is a lot of rotation happening, right? So when there is a rotation, completely from the right shoulder, thoracolumbar fascia, glute, your hamstring, everything works. Everything has to work in tandem. So that is the reason we work more on the rotational aspect for the bowlers.
Okay, fine. Suppose a patient, maybe we saw Shreyas here when he was jumping and then he got a tear. On field, okay. Suppose a patient dives or he does the run out, he got some. So what type of thing will make you, whether we allow the player to continue his game or we stop him and we have to send him back? What is the decision making criteria for that one?
See, again, on field, it is more of the initial assessment on the field, right? So depends on the movement. If they're able to do the movement completely, no, or if the range is good, and the pain criteria, and the special test, immediate special test, what we can do on the field. According to that, in the first 90 seconds, we need to assess and be in a position to tell, yes, he can continue, or he has to go back. So this is the criteria what we use.
Okay. Fine, yeah, good one. We'll see. Yeah, Sumit. Rotator cuff related shoulder pain. Yeah, it's a broad term. Maybe we talk about tear, tendinopathy and subacromial impingement. Correct. All three things. You treat these three things separately or you consider as a rotator cuff related shoulder pain and then you go as a standard rehab protocol for them.
No, I take as all as a whole, unless, okay, excluding criteria, okay, if it is like a large tears, which doesn't filled under, okay, rotator cuff related shoulder pains. It's impingement, it is tendinitis, it is bursitis, it is all rotator cuff related shoulder pain I treat, unless the test which is provoking the rotator cuff related shoulder pain, all are coming positive. So I treat as a general. I don't treat separate entity like, okay, pathological problems, all this, what doctors mention, impingement, if they mention, because the main focus is, okay, scapular based that time. So what is causing that, okay, structures to get, okay, into problematic stage, okay. So it shows in the evidence also, rotator cuff related shoulder pain mostly you will see with the movements in the scapular problem. That means, okay, movement disorders of the scapula. That means your rehab mostly designs based on the scapula. So you have to check, okay, if the scapular force couples are disturbed or the rotator cuff force couples are disturbed. based on that, you have to plan. So mostly it is not you have to treat the rehab plan separately for impingement, separately for bursitis, separately for tendinitis. It is not like.
Yeah. The rotator cuff, irritable, non-irritable.
Yes.
Okay. So how will you assess this thing? Irritability, what will be your treatment plan? Non-irritability, what will be your treatment?
So this I already took in the morning, workshop. So it's like based on the irritability classification system. Okay, I plan my, see other, if you take at the modalities, all that, it might be placebo effect, but I go mostly on the load management system, exercise system. So if it is high irritability, okay, then I plan mostly open chain exercise first, in the supine positions. Along with that, I work on the proprioception system. Then, if it is a moderate ability, so mostly adding weights with the same type, but if the patient goal is to achieve, some like the pain have moment of pain, it is closed chain. Then, along with the open chain, I add some semi-closed exercise also, because their goal is to achieve, something like, they want to do, gym type exercise, push-ups, all that. Then I will add mostly closed chain. But if the patient is just sedentary lifestyle person, he doesn't want to do anything, then I'll keep as an open chain exercise, but based on the irritability scale only.
Okay, when a patient comes to you with a shoulder pain, what makes you confident the patient is having a tear?
So it's like, the even patient is having tear, if it is not a large tear or not a massive tear, that it doesn't change my rehab strategy. Okay, but if the patient have a large tear,
Patient like subjective things, like maybe, or what assessment will make you to say, yeah, there is definite tear is there.
see, that's mostly the patient symptoms, and patient's observations, patient history, all that will give you idea. Patient might, if the mechanism of injury, like the patient have something they are doing repetitive overhacked activities from longer period of time, that might be rotator cuff got overloaded because of that. So they might have that, even the smaller tears, but the symptoms, you can't tell on the symptoms directly.
Okay, then I'll ask directly,
Yeah.
whether the night pain and weakness in the external rotation when compared to the other side.
That is what
will
I'm
that
telling.
have a role of-
Yes,
Yeah,
that
that's-
conclude here. It might be partial tear, but it might be large tear. So at the night pain will not be in mostly partial tear patients. You will see mostly in the large tear patients only night pain and constant pains, and weakness you will not see. You even the tendinitis patients, bursitis patients have same time of symptoms. Even the partial tear patients. So you can't decide only through assessment the patient have partial tears or patients is fixing into impingements, all that. But large tears and the other types of shoulder pathologies you can differentiate.
Okay, one last question for you. A patient comes with a joint side rotator cuff tear. They don't want to go for operation. What will be your rehabilitation goal?
See, first, if it is the
Joint side tear.
it is like articular side tear, what you so if the patient, so we have to explain to the patient first, if it is large tears, what will be the possibilities in future also. It might be because there are some research which has concluded some during rehab only the tear size has increased. So this also you should explain to the patients first. It might increase or it might decrease or your pain will go, but 50% patient fits into that. Not all. 100% patients will not get relief with rehab.
Fine. Yeah, again, being a sports physiotherapist, Vinayak, pain. What are the things you do for pain on field, off field?
So I don't treat much on field, but definitely in the clinic, what we generally do is for pain management.
You don't want to disclose? It's something copyright or something?
There's nothing to hide about it. See, pain management is very important and crucial part in terms of the rehabilitation. Everything cannot be done only through the exercises also, right? Sometimes cryo and I do dry needling therapy, we do taping, we definitely use for inflammation and all those things to reduce, definitely we'll have to use other modalities we have. So laser therapy, ultrasound, IFT, all those things we
How
do.
will you choose? There are so many things. For one patient, we can't give everything because
So-
it's like an expert thing. Because panel means-
Definitely. Yeah. So let's say there is a patient with. Can you give me an example, like certain type of patient?
Maybe again we can say that he is going throwing. Okay, he just give the thing of throwing. Okay, he has pain with some noise, something like that. When
Right.
you see trigger point also there. Okay, which one do you give priority? You try maybe a click or something is there, labral is there. You
Right.
try to treat a labrum or you try to treat the trigger point. How you
So in
make your
that case,
decision?
probably first I'll go with the to improve the movement. We will have to use the manual therapy to improve the joint extensibility and flexibility of the muscle. Treat the trigger points if it is there. I mean, all those things for the pain management perspective, I'm saying. And then we start with stabilization exercises, basic, what do you say, isometrics or something like that. And then icing definitely would be a part of this. So that's about it. Like for those patients, we're not gonna do the IFT and all those things. They're not gonna work out. Yeah.
Yeah, fine. So maybe some interesting thing you can say. I did this, the patient feel better. So something like that for the thing, what you can say.
There are in many cases, see, I also deal with a lot of patients who have psychosomatic issues also, right? So I feel many of the problem comes from psychosomatic issues also. So stress related, this, that, also creates a little
So
lot
what
of
you
issues.
do? Maybe the
Frozen
biopsychosocial.
shoulder, let's say frozen shoulder.
Ah.
In frozen shoulder cases, when we are working, we teach them a lot of relaxation techniques apart from the exercises and all those things. Then we do dry needling therapy to release the pain and to improve these things and all. So these things really help a lot.
You just take a concept of the biopsychosocial also.
Yes,
That is the
yes,
emerging
yes.
thing. For all pain, we are just getting into the thing.
Yes.
So now another 10 minutes the clock shows. Huh? We want to close? Okay, we will close. Yeah. Himanshu has some question. Yeah, ask him.
Okay, so non-painful clicking sounds in shoulders are there. So is this non-painful clicking sounds in shoulders, are they something to consider about, and what is your explanation for that?
Yeah, when clicking happens without pain, that's fine. Okay, there may be some dyskinesis, something like that. Always see again the scapular dyskinesis. Okay, no one will have a proper scapula. T3, T8, nothing will be there. There will be some sort of dyskinesis will be there. We correlate with the pain pathology. Okay, click is there. Yeah, it's an indication. You try to do the stabilization exercise, make them proper. Unless maybe the patient will come to you when the pain is provoked. It's not that I had some click like that. Normally they used to get. That's what I feel. Anyone wants to give your inputs?
Why he is asking? Because there are some patients who ask why these clicking sounds are coming.
Yeah, that's what.
So
Maybe that dyskinesis, some muscle imbalance is there. There are some underactive, overactive. You try to balance, that will be fine. Okay. But unless we will always correlate with the pain. When there is a pain, there is pathology.
So we can assume that So I think as a physiotherapist over here, many a times patients come to us and they will go to other physiotherapists. So I think in this consensus we can tell that a clicking sound from the shoulder which is non-painful is something which you can ignore.
Ignore, no? It
I'll-
can be, yeah. We
I'll-
can.
what they questions? Okay, that's what. Okay, and so what they ask questions? Okay, why only this shoulder is having sounds? Why not this shoulder? Okay.
That's what. See, the answer is you have to be smart enough, dominant,
No.
non-dominant. Okay. So many things will have a role. Okay. If clicking is a problem, okay, you can try. Address the thing. Try to see that you do a proper assessment, underactive, overactive. You balance it. It will become fine. Okay. So I don't think so. It's a major thing. Maybe laxity people, we do something like that. We also often get the clicking. Okay, until unless even the sports people, anyone, I say when pain is there, correlate with some pathology. Otherwise, it's fine. Yeah. Yeah. Now more. Yes, sir. First, Parthiban, sir.
Hello. Good evening. My question is to the physiotherapist next to Uma Sangar. You have given a very nice explanation about the anatomical trains, and if for us a right side shoulder pain, we are supposed to work on the left side glute based on the posterior oblique chain and etc. My doubt was, I heard about the fascia supposed to go for tightness and we have to release. Can we strengthen the fascia by doing an exercise? Or the fascia strength is considered, because you are telling like for a right side shoulder pain you have to strengthen the left side glute.
Correct.
So first time I am hearing the strengthening exercise in terms of fascia world. Can we strengthen the fascia or not?
We cannot strengthen the fascia.
Oh, okay. What is the
It's
rationale
only
for the
the
exercise?
releasing of the lumbothoracic fascia.
No,
or
you had told
thoracolumbar
to
fascia.
work on opposite side gluteal muscle strengthening.
Correct. So the anatomical change, the muscle connection is there through the fascia. So we release the fascia and strengthen the other muscles.
Release the fascia.
And strengthen the glutes and the shoulder. Opposite. Yes.
Can I answer that question?
Yes.
Okay. Hi everyone, my name is Aarti Prasad. First of all, let me congratulate the whole crowd for staying awake even at this time. Congratulations to all of y'all and participating and asking questions. Wonderful crowd. Okay. Just wanted to add a comment. This is called as, what I do is neurokinetic therapy. In neurokinetic therapy, as you said, that the glutes max is connected through the fascia on sometimes to the latissimus dorsi also, the latissimus dorsi. So you look at the POS, as he said, the posterior oblique chain, you look at it. The fascia generally has a tendency to get tight. It's the muscle which gets weak. So the fascia never gets involved except in getting tight. So you just have to look at releasing the fascia, strengthening the muscle.
Yes.
That's the way you go about it.
Okay, thank you.
Just want to add just one more thing. Nandan was mentioning that we do this, we do that. All the physiotherapists have different ways of doing. So I was going through one study in who's a well-known physiotherapist in India. He sent a survey to a lot of people and he wanted to find out how good, what did they do, how they felt with the shoulders. All the physiotherapists, the answer that came out, the questionnaire was, all the physiotherapists had their own way of treating shoulder and everybody thought that what we are doing is right. There's nothing wrong. Absolutely nothing wrong. This is what the survey showed. The survey showed that all the physiotherapists were doing good work. So what we are finally looking at is giving good results to the patient. But having said so, please continue to attend these kind of conferences so that we all gain knowledge and our knowledge becomes more scientific in our approach. That is the only thing I wanted to mention. Okay? That answered your question?
Thank you.
Next question. You want to ask one more question?
Okay. My second question is to
Second question. Abhishek, come.
to Uma Sangar.
After that, we'll see. Time is there. Abhishek. Will say.
Okay, this question is to Dr. Sumit. How do you actually isolate in your assessment to know the impingement is because of your rotator cuff muscle or if it's because of other subacromial contents? How do you actually know? It's because
What was the definition which I told you in the morning?
Yeah, I know. You look at it globally. I understood
Yes.
that part, but how would you know?
That is what the evidence says.
Yeah.
Okay, you can't tell it's a subacromial impingement.
Okay.
That is what it's a old terms. It is like medicals keep on changing. Okay, so what you see that subacromial impingement, it is one part of that contributing factors. Okay, which cause the rotator cuff involvement or dysfunction. Okay, so normally which I told you, the near impingement test, Hawking test, all that, which is already, but it has less sensitivity and specificity. So based on that, you can't decide it's only impingement which is causing. That's why I told you the subacromial space, they said it is causing the compression of the rotator cuff muscles. But what I told you, the research says the tears are not happening in the bursal side more. Tears are happening in the articular side more. So that means you can't tell the name only impingement syndrome. So based on that means if it is not impingement, how you can decide the test to diagnose that? Separate entity. Okay.
That's what. It's a cluster of symptoms.
It's a
cluster of
heterogeneous syndrome.
symptoms. Huh? Okay, maybe we can't say that this structure is at fault. The Cochrane review says, whatever the thing based on the impingement say, they say that we can't say that structure at fault. We can say the impingement is present or not with the test. But we can't identify the structure because there are so many problems that may lead to impingement. Okay, fine. One last question from, then next you. We finish with these two questions. Ask. Your good name? Next you can. You can.
Sir, so when do we exactly address SC joint and AC joint in shoulder rehab?
Anyone wants to tell? AC joint, SC joint. Okay. SC joint commonly, it won't have much of the role in the thing. What SC joint will do is the posterior rolling. Okay, the posterior rolling of the clavicle at the end range. Okay, AC joint, when we consider in shoulder, AC joint, they say that pinpoint. Whatever the patient is having a acromioclavicular joint problem, they will come and point that I am having a problem over here. Okay, again, the studies have shown that the last 10 degrees of the thing will be more contributed to the AC joint. Okay, when some patient, those who are not getting the full arm elevation, the clavicular posterior rolling is having a role in that, but very minimal thing. You can do the clavicle inferior glide or a posterior rolling you can facilitate, they'll get better with the elevation, arm elevation. Any other thing? Fine,
First of all, my question is, Dr. Karwan sir asked to Dr. Vinayak, someone has came with the pain while throwing like that, but Dr. Vinayak has said that isometric, we will do taping like that and all. But while having isometric, the pain will increase. I have studied some research, I don't know about fully. But
Maybe
better than
activation.
isotonic is better than isometric.
Activation.
I think.
See, that's
what
what
about
isometric, isotonic. Initial painful stage, we do the activation exercises.
Okay,
obviously. Activation exercises. Then when the pain intensity, see, that's what. No, whatever we progress, initially we won't go for the closed kinetic chain, all those things. Open thing, activation exercises. We term it as an activation, it will be more safer. Then isometrics, then isotonic strengthening with the progressive load.
Stages of
it is a non-surgical question.
Non-surgical, yes. Non-surgical, but then there are different stages at which we are doing different types of exercises. So since the thing was just for the pain management, I was like, it's very difficult to, again, specificity of the injury is very important for us to understand, to be able to answer that.
Thank you.
Anything? Thanks everyone. Thank Dana, Nandan, Uma, Gautam, Vinayak and Sumit. Thank you.
I would like to thank Dr. Kavanan for